Today I'll be talking about a paper that was published yesterday in the Annals of Internal Medicine. It's about a clinical screening tool for predicting future firearm violence, and it's called the SaFETy score. So Dr. Richardson, clearly Rebecca also understands the importance of, it's a catchy acronym. We had a whole brainstorming session about it. So just the background, of course, firearm violence has a tremendous mortality and monetary burden, and given in past studies, the ED has been a place for successful violence-based interventions because they're an access point for difficult to reach populations, and the prerequisite that's missing to apply this kind of logic to gun violence is that there's not really an effective way to gauge risk, and that's really the purpose of this study. So what we really sought to do here was to define an empirically derived risk score that met two criteria. One, it's easy to administer, and two, it doesn't rely on questions that are not likely to be ascertained accurately without an NIH certificate of confidentiality. For example, the strongest predictor would probably be to ask someone how many people they've shot in the last year, but that's not really very feasible to ask that question. So we are restricting focus to questions that would be easier to ascertain. So what we did is we applied predictive modeling methods to a 2-year prospective cohort study to do this. That prospective cohort study was the Flint Youth Injury Study, PI'd by Dr. Cunningham. The basic study design for that study was patients aged 14 to 24 who entered the ED with an assault injury were candidates for screening, and for each assault injured person that came in, the next available person who was not assault injured, who was of similar age and same gender, was also a candidate. And exclusion criteria included sexual assault, child abuse, and suicidal ideation. And for the entrance into the longitudinal study, past 6 months drug use, any drug use was required. And for those who did enter the study, they were ascertained every 6 months for 2 years. So of the people that did enter, there were 599. A little over half were assault injured, a little over half were male, and a little over half were African American. And this was in the Flint ED at Hurley. Average age was about 20, and there was very high follow-up rates throughout the study. So the measurement that we used here was one used in a prior publication by Pat Carter of any gun violence, victimization, or perpetration. And this was ascertained through a combination of chart review and survey responses. Of the 599 people, a little over 80% could be definitively classified as either having gun violence or not, and a little over half of those screened or were positive for gun violence during the follow-up. So of all of the measurements in the study, and there were hundreds, about 118 ended up meeting the criteria of being able to be asked reasonably in an ED without a certificate of confidentiality. That included 39 measures of received violence experience, community violence exposure, mental health symptoms, questions about drug and alcohol use, peer and parental behaviors, questions about retaliatory attitudes, and basic demographics. So the basic approach to doing this was we withheld a quarter of the data set, and using the other 3 quarters, we tried to build this risk score. So basically what we did on that training data was the first step was to rank predictor importance, and the way we did this, just super briefly, is using a machine learning method called elastic net penalized logistic regression, and it's very similar to regular logistic regression, except the coefficients are shrunk in a way that optimizes out of sample prediction. And the ultimate effect of that is usually to shrink a lot of the coefficients to 0, thereby eliminating variables automatically from the model. The second step, which was the only real human step in this process, was to look at the highly ranked variables and pick some that we thought were both important and had distinct content. And then after selecting those variables, we derived cut points because we thought that would make it easier to administer, and then we determined point contributions for each of those cut points. And it's in a very similar manner to the way the Framingham risk score point contributions were calculated, actually. And because there was about 20% missing outcomes, each of 1, 3, and 4 involved multiple imputation at each step. So results, so basically there were 20 variables out of the 118 that were deemed to have some relevance. And by far the most important was your own experience having a gun pulled on you. And the second most important was very closely related, how many times has someone shot you. So to summarize this plot more parsimoniously, there are basically 4 categories of variables that were selected. Violence victimization experience, community violence exposure, peer and parental influences, and fighting. So from those 4 categories, the 4 variables we ended up picking were, and these mostly were the highest ranked in each of these categories, were frequency of being threatened with a gun, frequency of hearing gunshots in your neighborhood, how many of your friends carry weapons, and frequency of getting in a serious fight. So the cut points that were derived for these, so for being threatened with a gun, the cut points ended up being never, once, and twice or more. For frequency of hearing gunshots in your neighborhood, it was basically whether or not you had said many times. For friend weapon carrying, it was basically whether or not you said many or more. And for fighting frequency, there were 3 categories, and it was never, 1 to 5 times, or 6 or more times. So the actual point contributions that came through with this were that for the serious fighting outcome, you got 1 point if you said 1 to 5 times, and 4 points if you said 6 or more. For the friend weapon carrying, you got a point if you said 3 or more, or you said many or more. And for community environment, or meaning how often have you heard gunshots, if you said many times, you get a point. And for firearm threats, if you said once, or if you said you'd been threatened with a gun once, you got 3 points, and 2 or more times, you got 4. So using a score calculated in this way, you get a 10-point score based on the responses to those 4 questions. And the solid black line here is the risk gradient. And because the sample size here wasn't huge in the validation set, we combined some of the levels of the score. And the solid black line is in the training data. You can see that basically your risk jumps from 10 to about 40 to 60 to 80 to 100 as you get higher levels of this score. And in the validation set, you basically get the same gradient, which is good. And similarly, if you just look at the distribution of the score, you can see as you move to the right, the firearm violence group is more highly represented. And you get basically these levels of future firearm violence prevalence for each of these levels of the score. And I don't think I was clear about this, but this is firearm violence over the entire 2-year follow-up period. So, for example, if you got a 6, 2, and 8, out of those 16 people, 81% had firearm violence during the follow-up period. One of the key components came up while writing the paper and during the peer review was to show that this does better than just knowing the person was there for an assault injury, because I guess that is the way to do that. That would be the previous way to determine someone's level of risk. And so if you just look at whether or not the person was there for an assault injury, that does correspond to over a double risk as compared to someone who was not there for an assault injury. Whereas if you just look at the safety score by itself, each additional point gives you about 47% at excess risk. And if you put them in together, you can see that the reason for ED visit is no longer significant in that model, but the point estimate for the safety score is about the same. So what this tells me is that assault injury is important, but once you've actually incorporated the score into the model, it's not really that important anymore. And also, this is not shown in this table, but as a standalone predictor, if you were to compare the score versus just reason for ED visit, you get the safety score is substantially more powerful of a predictor. The way that we were billing this in the paper and in real life is to couple this score as a means of risk stratification with prevention tools. So So this would actually allow a basis for using the ED as a way to prevent firearm violence. So for people who, for example, score higher than 5, those would be the ones you would consider for the most resource-intensive programs. The middle range, 1 to 5 is somewhere in between, and the lower scoring individuals may be the targets for primary prevention. And it's the kind of prevention we were thinking about was maybe therapeutic interventions to lower impulsive behavior, or maybe gun safety efforts. So anyway, basically, I would say one of the caveats with this is that clearly someone presenting with a violent injury, even if they score low on the safety score, probably shouldn't be ignored. And therefore, this is probably most applicable for people who come to the ED for reasons other than a violent injury. So just real quickly, this caveat is that clearly this was an internally validated, not externally validated, tool used in a single ED, and I think also this was based on the analysis of data on drug-using youth. But I would point out that most of the people who got into the study for drug use, because of their drug use, were marijuana users, and there were not huge rates of use of other drugs. So you might think of this mainly as applying to marijuana users who came to the ED. And another caveat is that we only had measures of depression and anxiety in the mental health components. So it wasn't really, there might be other mental health factors that were not accounted for here. I think that what we really want, what I would imagine would be a good next step would either be external validation or similar types of methodology used for other study populations to see if different types of risk scores could be more relevant there, and that's about it. So acknowledgements is of course the main study funding, the FYI whole investigator team and the study staff, and the staff at Hurley. That's it.
Questions for Jason?
So this is really neat stuff, the approach to gun violence as an epidemiologic problem, and given your finding of these risk factors being things that interact with other people, not only as an epidemiologic problem, but sort of as a contagious disease problem, is interesting. What I guess I wonder, is there anything, and nothing comes to mind, but are there statistical assumptions that we do in epidemiology and contagious diseases that are different when the contagious disease that we're looking at is behavioral rather than microbiological?
Well, I mean, yeah, I guess so. I guess I would think the difference with an actual infectious disease is that I would assume the transmission rate would be a lot lower with the behavior, because it's not like because you're exposed to someone you would have an automatic transmission. But I think also it could be, I think the main thing that we were hoping was to have, I don't know if we were thinking about the actual neighborhood risk or the friends carrying weapons as necessarily contagion. It's more like exposure to violence is sort of what we were thinking. But yeah, I definitely think there's definitely literature on the association with violent peers as being an important driver of violence. And I guess the main thing I would think of as a way to handle that, I guess, would be therapeutic interventions that make you more resistant to negative peer influences. Whereas but you can't vaccinate the same way you would with the actual infectious disease.
Not yet.
Yeah, maybe.
Other questions for Dr. Goldstick?
Thank you for your presentation. So could you talk a little bit about how you got almost 500 adolescents to answer 118 questions, however many times it was over 2 years, with an 85% response rate or something?
That was way more than 118 questions, right, Rebecca?
So this was a 5-year R01 from NIDA. So we had a baseline assessment of 2 hours in the Hurley ED that most of you who were ever at the Hurley ED probably didn't know was going on in the background behind you in laptops and tablets with RAs asking questions. And then every 6-month follow-up with home visits with staff of 1 or 2 people. So they would either come back to Hurley and we would compensate them for their time to come back to Hurley, or we would go visit them in their home with staff of 1 to 2 people for safety every 6 months for the following 2 years. And people were generally interested, and we had a intensive staff of follow-ups. When you're doing clinical studies, this applies to all clinical studies, don't happen in phone calls from the office from 9 to 3. So they're often evening home visits. We didn't do visits after dark. We often would meet people in the local community locations, McDonald's, the library, the school, somewhere else. And we would go to them, and we would do it for them on the weekend or in the evening or when it was convenient for them. And we had a staff of between 2 or 3 full-time dedicated staff that their only job was to track down follow-up people and do them.
You're writing a paper about the
Yes,
procedures
Jessica
too.
Roche, one of our staff, is writing a paper on the follow-up methods for achieving follow-up rates. And those follow-up rates are achievable. It's like everything else is about money. It takes a lot of staff time to get really good follow-up rates. So, for other folks, when you use the cage, which hopefully you aren't using anymore for alcohol, when you're not asking anybody the cage, I hope nobody is still asking anybody the cage. If you are, talk to me and I'll give you the better answer. But if you ever wondered how the cage was developed as like a quick mnemonic screen, this is sort of the process, and this, in theory, can be the cage for how we estimate risk for future firearm violence. Hey, Jason.